myself and Colin are here today to talk about how reconfiguring trauma care within Northern Ireland, right from the roadside to recovery. I work in the emergency department, and patients only really stay with us for a very short period of time. And it's really Colin and his team who really get the patients back up on their feet again and really home to their families. So constantly in awe of the work that the whole teams do. Okay, next slide. I don't think we can really talk about trauma care within the north of Ireland without talking about Dr. John Hines. Dr. Hines was very passionate about pre-hospital care and the development of a trauma network within Northern Ireland. He met with the Health Minister, Simon Hamilton, back in 2015, or in and around May time. But sadly, he lost his life that July at the Scaries races in Dublin. And it was after that, next slide, please. It was after that, really in the September 2015, that Minister Simon Hamilton launched a public consultation regarding a trauma network for Northern Ireland and a HEMS public consultation. Okay, next slide. Within the public consultation, the Royal Victoria Hospital in Belfast was designated the major trauma centre for Northern Ireland. It kind of had been default the major trauma centre anyway over the past few years, but it was designated within Northern Ireland as the major trauma centre, supported by trauma units throughout the north. The helicopter as well, there's lots of passion and public support for helicopter emergency medicine within Northern Ireland. So that was very much formed part of the public consultation back in 2015. Next slide. So yeah, so really momentum began back in 2017 regarding developing the major trauma network. Also in 2017, the helicopter emergency service was launched as well. It was a wee bit weird and surreal at the time that we actually had a helicopter doing its first flight, but we didn't actually have a true trauma network within Northern Ireland. But we've progressed so much further now. So this is the wee structure there is really how the major trauma network and clinic is within Northern Ireland, reporting up to the Health and Social Care Board, the PHA. Our trust chief executives are involved. There's a trauma network board as well as the HEM service. Nursing and nurses form a really strong voice within the development of the trauma network, and we can't underestimate the influence that nurses can have, especially regarding the co-design of services, enhanced rules, workforce planning, and the contribution to research. We know within the nursing and AHP subgroup, we have shared clinical expertise and supported each other with regards to any fears or anxieties in the development of the trauma network. I think from my colleagues who may have worked in peripheral hospitals, there was a fear that they wouldn't see any patients who may have suffered a trauma anymore. But that's very much not the case with regards to the trauma network, and it's about us all working together for the best of our patients. Okay, next slide. So again, before HEMS, the trauma network, the identification of trauma units within Northern Ireland, there was a lot of work done in the background. Northern Ireland has a population of 1.8 million, and we have hospitals. Some people say we have too many hospitals, and we have lots of hospitals spread out throughout Northern Ireland. The map on my right, which is probably your left, shows the 45-60-minute drive time to the Royal Victoria Hospital in Belfast. After that, that's very much in the red shaded. Those are the areas that you cannot get to the Royal within 45 minutes. And I suppose this map is significant whenever we introduced the trauma bypass just last year. Okay, next slide. Super. So within Belfast, We have done a lot of work with regards to the development of the trauma team and identifying the roles and how we work together. Anytime I see the trauma team in action, I'm completely in awe of what they do. It is very much like a Formula One team. Everyone knows their roles, responsibilities, and are there, you know, for the best of the patient. In the trauma team, there has been a lot of negotiation about getting the right skill and the level of seniority within the trauma team, and making sure that everyone responds and is there for our patients. And those members of the trauma team are clearly identified. So I'm happy to share any work that we have done with regards to the trauma team and how it's developed and involved in Belfast after. Okay, next slide. I've put up this slide because I find this really, really good resource for nursing with regards developing our service, regards developing training and the training of nurses within the department. The National Major Trauma Nursing Group, London, I suppose, and the Pan-London Trauma Network have been in operation for years, and they in some respects were a wee bit further than us, or had just gone through the journey sooner. And they have developed level 1 and level 2 competencies with regards trauma care, as well as looking at the nursing competencies that are required for trauma wards, education, pediatrics, and critical care. So a really good resource is this group if anybody is looking to develop competencies or just really bounce off ideas and develop further networks. They're a really good group to link with. With regards to training, every year within the department, we probably send 2-4 people on TNCC, ATLS if we get the money, the European trauma course, but it's actually a small number of nurses who get the opportunity to sit these courses on a yearly basis. So we very much knew that we needed to do most foremost, and we developed TILS course. This is Trauma Immediate Life Support course. The person who developed the course is a guy called Bruce Armstrong, works in Southampton, great guy. We brought him over to Belfast, and he in essence gave us his course, his slides, and helped train the trainers within the TILS course. And we do run this a couple of times a year in-house, all, especially probably the more junior nurses and the senior nurses for updates, find it very beneficial. You can tweak the course to meet your department's needs, as well as if there's any trauma that may have went a wee bit better, you can run scenarios within the TILS course. We had a slight issue with regards massive blood loss activation with our portering teams, our labs. So within the TILS course, we incorporated our hemovigilance nurses and massive blood loss nurses within that, very much to teach all the staff and learn from each other. Doctors, nurses, AHPs, NIAs, all have the opportunity to attend the TILS training, and it really brings in the sense of team working within the department. Okay, next slide. This is just an example of the major trauma patient book that has been developed and used regionally throughout Northern Ireland. Whenever a patient who suffers major trauma comes to our department, this is the first document that the scribe will get. It is a book that travels with the patient throughout their hospital stay. And if you start your journey in a trauma unit in Northern Ireland, then the guys in the emergency department there will start this documentation, and then that will travel with the patient up to the Royal. And with regards collecting information, being able to audit research and benchmark, having one documentation regionally has been very beneficial for our TARN data collectors, and it's standardized. So yeah, thank you. Next slide. This is just the major trauma triage tool that our ambulance service use. This was very much in relation to the trauma bypass. So what does the trauma bypass mean for Northern Ireland? If you're within 45 minutes of the major trauma centre, you will go straight to the Royal Victoria Hospital. If you are outside of the 45-minute window, then you will go to the nearest Type 1 ED, the trauma unit, to be stabilised prior to being transferred to the Royal. This is all with regards to trauma bypass. I think last year we had COVID and we were turning on the trauma bypass, and we were very nervous about the number of additional patients that we would get to our emergency department when we were, like all emergency departments, you know, battling many things at the one time. But in essence, it's probably related to one additional patient a day. And look, this is about getting the patient to the right treatment first time and delays in care. And so this trauma triage tool very much supports the ambulance service in bringing the patient to the right place and preventing unnecessary secondary transfers. Okay, next slide. Yes, so this is the call and send. Call and send. So if there are any patients who are seen in any of other or emergency departments and they need transferred to the Royal Emergency Department, the call and send protocol will be instigated, and the patient will be met by the trauma team in our ED resus. And so, as I said before, you know, always in awe of people and their focus on improving trauma care. Our journey in Northern Ireland, we're still on a journey and to improve trauma care for all our patients. But with regards how we do it in the emergency department, we're standardising it more. We're inputting data to Tarn. We're able to benchmark ourselves. So I'm going to pass you over to Colin now, who, as I will always say, we do the first 30 minutes. Colin and his team do the rest of the work to get the patient home to their families.
Thank you, Linsey. That's great. Next slide, please. So as Linsey said, the first hours after trauma are absolutely crucial, and our colleagues in the United Kingdom had told us that an effective functioning network can increase your rates of non-expected survivors by up to 20% and beyond that. So it's really important that if you've got an increased rate of survivors, that you also have the processes in place to make sure that they get their lives back again and can achieve the best functional outcome as possible. For that reason, the Northern Ireland Trauma Network have invested really heavily in rehabilitation. Historically, I think rehabilitation has been viewed as something which is slow stream, doesn't happen until a long time into the patient's journey, and that's very much not the case or the ethos that we follow. So for us, rehabilitation starts really as soon as the patient leaves resus, and we aim to have the first assessments undertaken within 24 and certainly no later than 48 hours afterwards. Next slide, please. This little diagram here shows just a little bit about the pathways that patients will go on after once they're admitted into acute care. So from resus, you'll be admitted to regional intensive care unit, theatre obviously, or indeed the major trauma ward, which is our new unit, that's what I'm going to speak about shortly, or their single specialty. So if they've only got one system involvement, then that's usually best managed by that individual specialty. From onwards there, then the rehabilitation processes can involve going to a specialist centre for brain injury management, or indeed perhaps to your closest hospital, or indeed community-based rehab. Next slide, please. This is our major trauma unit. So this is our ward, which opened up in September of last year. So it's an 8-bedded ward. It's all entirely side rooms. It's a lovely unit. So we're staffed by a consultant of the week who is a visiting consultant. We have a team of 10 from one of the other specialties. So this week we have a general surgeon working with us. Next week we have somebody from trauma and orthopedics. The week after that with a neurosurgeon. And they just rotate through. It's a surgeon with an interest in trauma who's willing to look after the unit midweek. But individual patients will still be required to be seen by their individual specialties for their injury. Alongside that, then we've got our 2 non-medical consultants. So that's myself and my colleague Julie Grant, who's a consultant physiotherapist. We are on the ward every week. And we'll review or oversee the care of our patients, particularly in regards to rehabilitation. We have 2 trauma coordinating nurses, and they will follow the patients right away through their journey, link with families and help with repatriation. We've got 5 clinical fellows or doctors, and we run on a minimum staffing of 3 nurses and 2 healthcare support workers. And part of the reason why it seems quite high is we need to be able to log roll patients. And it's very important that we don't forget our IHP colleagues. So we have a full complement, 2 physios, 2 occupational therapists, dietetics and speech and language input as well. Next slide, please. So our patient profile, we see all sorts of different injuries, but by far the most common presentation is road traffic collisions. Falls from height, that's usually through a roof or off a ladder is what we've seen. And then assaults, mixed into that we get some stabbings, and obviously we've got our industrial and farming accidents, so we get quite a few crush injuries, and we've actually had a number of those in the last week as well. The types of injuries that we see, so most common injury that we see would be broken bones, obviously orthopedic type injuries and nerve injuries from that. In about 70% of our patients. Mixed into that, there was a very high percentage of thoracic trauma, which we were quite surprised just how high that was, but very high incidence of that, followed by neurotrauma and traumatic head injury. It's also very important to mention just silver trauma, so that's our over 65s, and what we find is somebody who's aged over 65 will maybe sustain very significant injuries from falling down 1 or 2 steps that somebody who's a bit younger might sustain from falling off a roof. Next slide, please. So when we're talking about measuring our outcomes, I know Linsey mentioned TARN, which is a Trauma Audit and Research Network. In a nutshell, TARN is a national registry and it collects data from the UK across Europe. Now I understand that South are also inputting into TARN data. This measures everything, really detailed. So once the patient's discharged, our TARN coordinators trawl through the notes for a couple of days. They measure everything from the length of time it took the patient to get to CT, the level of doctor who saw the patient, how quickly got to theatre, all the various aspects of the rehab as well. And then our outcomes are benchmarked against other centres. At the minute, we're benchmarking against UK and are doing very well. Next slide. Just some of the TARN data has suggested. So we see approximately 3,000 cases of trauma per year, and of that, 1,000 cases are what's termed as having an injury severity score of more than 15. So that's our most severely injured patients. And the cost of it's massive, £4.3 billion annually. That's in lost income, injuries as well. So it's huge economic income, or huge economic impact from major trauma. And it's really important that we have the processes in place to minimise that. Next slide. Thank you. So some of the developments that we've had over the past 2 years, we've been working on the regional rehab prescription. So again, that's something which is TARN eligible and TARN audited. And indeed, our colleagues in the United Kingdom mainland, if the rehab prescription is not actually completed, they don't get funded for managing that trauma patient. We work in a slightly different system in the north. But rehab prescription effectively documents a patient's condition and rehab status throughout their journey in the major trauma centre before repatriation, and then they're provided with a copy and discharge. Another development we've had is the implementation of using blockade techniques. So this is initially being pioneered by our anaesthetics team here. But what we're able to do, particularly for blunt thoracic trauma, is put in erector-spinae blocks, lumbar plexus blocks, so it can provide a nerve block to the specific injury that's injured, and reduce the need for high-level morphing, which is much better for the patient long-term, but it also helps reduce the risk of delirium and complications like that. Much more comfortable. It's a double-edged sword though. Once we put in a blockade, the patient tends to stay with us for about 5 days, whereas originally the plan for the major trauma unit is patients would have passed through in 72 hours and been repatriated. We can't do that where we've got blocks cited that the patient has to stay with us a bit longer, but the difference that it makes to care, it's absolutely worth it in the longer term. Myself and my colleague Julie, we've set up a major trauma review clinic. And to my knowledge, it's only been recently set up in Keynes in London. So this is a very new thing, and it's where we're combining appointments for patients. They come to see myself or Julie, and we've got some orthopaedic support at that clinic as well. And we'll follow up thoracic injuries at that clinic, simple fractures, so clavicular fractures, we can x-ray them. And we can look at the patient as a whole. So whereas previously a patient might have come back and had their femur fracture looked at, we'll bring the patient back, we'll look at their fractures, but we'll look at every other injury and how it's impacting on them as well, look at deprescribing, returning to work and things like that as well. One thing that's been lacking in our initial business case was input from psychology. I can't stress this enough for you moving ahead if you are thinking or getting involved in the trauma network. Psychology is really important. These patients are really affected psychologically after their injuries, and that's so important. And that's probably our #1 priority at the minute, is to try and get psychologists on board with the team as well. And reverse referral, so that's how we have a call and send protocol to get patients to the Royal. We also need to have our back doors opened as well. So before you open the front doors, you need to be able to make sure the back doors are open, you get flow of patients through. And that's the process by which we repatriate patients back to their local hospital. Beginning of the year, we were badly affected by COVID, so our numbers were much quieter, but over the last sort of 4 to 5 weeks, the numbers presented to the hospital with major trauma have absolutely exploded, and that's become really apparent now that we need a really good reverse referral pathway to get patients back again. Next slide, please. So our key messages, just for you moving ahead then. I think, as I mentioned, before you open your front doors of the hospital to bring in major trauma patients, you need to have your back doors opened to make sure that we can get an effective flow of patients, or you'll end up with a big backlog in resus, and that benefits no one. Your reverse referral pathways are really important for that. Cannot stress enough to the importance of psychology input. But I think the overall message that myself and Linsey would have is it's all about teamwork and coordination. Major trauma is much bigger than any one person. It's about a whole team working together, pulling together specialist input to get the best possible outcomes for the patient. And then final slide, please. Just for myself and Linsey, thank you very much for your time. If you have any questions, we're happy to answer them, or indeed feel free to email either of us and we'll do our best to get back to you.
That was brilliant. Thanks very much, guys. Really enjoyed that. It certainly seems worlds from, I suppose, what we have in the Republic, in the sense that we've 26 trauma receiving hospitals, one in every county. So trying to narrow that down to, you know, a centre in Cork and Dublin with a couple of trauma units, it does seem very far away, but it sounds like you've done a really good job with it. One of the questions I just wanted to ask you was, from the time it was announced by the Minister for Health in Northern Ireland, how long did it take to put it all into place? Because obviously we've made an announcement now where the trauma centres are going to be. You know, I wonder, you know, down here anyway, I suppose things are slow to change and slow to happen. How quick did it happen for you? So 2015,
public consultation, 2017. 2 years we had a helicopter, so the helicopter kind of, they were both working in parallel, so the network was working in parallel. So we officially went trauma bypass last year. Is that 2020? Yeah. So 5 years.
Okay.
5 years.
Yeah. So we're probably at the stage now. I think we've one of maybe two helicopters now in the Republic providing aeromedical transport. So I suppose we're getting there now. I was actually very interested in Colin's talk, actually, because it was, as ED nurses, Linsey, we don't often get to hear about what happens to the patient after they leave the department. So it was nice to hear what happens, you know, on the trauma ward itself. So I found that very interesting. Just another observation I've just noticed, and it was the very first point in your advice to us in relation to moving forward, was to look backwards and our step backwards, I think you said. And I suppose we have a chronic problem with overcrowding here. And, you know, one of the hospitals that we are looking at putting the trauma centre in does suffer with some severe overcrowding. So I suppose that will be an observation on my part as a nurse here, looking at how things are going to move forward and how they're going to manage to introduce a trauma centre in a hospital that's really overcrowded. And I know Cork's is no different, but hopefully the powers that be will be able to look at that and sort it out for us.